So I think interestingly enough, and also one of the late-breaking abstracts of this meeting, they will be presented the EMN trial comparing 4-drug versus 3-drug induction in the context of autologous transplant, showing, extremely like GRIFFIN, very high response rates, very durable response rates, and a very high rate of durable MRD negative complete remissions, which is probably the most important surrogate for long-term disease control in myeloma. So I think it's still, in the context of a 4-drug induction and autologous transplants, these are the best results we've ever seen. And I think it will require another randomized trial showing that with a 4-drug induction, a high-dose melphalan does not contribute anything. But based on both the GRIFFIN and this trial, we will see that there's a significant deepening of response after high-dose melphalan in patients who received 4 cycles of a 4-drug induction. So I still think that there will be a role for transplant. I think it'll become more nuanced in the future. Older patients, such 70-year and older, who have a deep response to 4-drug induction may decide to forgo high-dose melphalan consolidation and thus continue on maintenance therapy as long as they're responding. But I think it's essential that these patients have stem cells collected to consider for, salvages if the disease turns to come back. I think the other thing we will be seeing in this meeting is more long-term survivals of all the older studies that have been done in the context of transplant. So I still think there will be a role for it. It'll be more nuanced in the future. And access, which we'll also see in this meeting, continues to be a major issue, that only less than 50% of patients who could potentially benefit from high-dose melphalan are getting this treatment in the United States.